Had Dr. Ravi Ranjan, sir, he's from Patna, and he's going to talk about his initial days uh, or initial difficulties during DCR surgery. Dr. Ravi Ranjan, sir, has like many years of experience when it comes to oculoplasty and DCR, and we very fondly call him the father of DCR, the local father of DCR, if I am correct, right, sir?
Thank you, AIOS and Deepak, and thanks, Mamta, for nice introduction. My topic is initial problem faced during DCR surgery. No financial. That DCR is the creation of low resistance pathway from the canaliculi to the nose by means of creating an osteotomy of the bone adjacent to the lacrimal sac and opening in the larger lacrimal sac. As you all know, it can be performed by an external or endonasal approach. My personal communication with many ophthalmologists revealed that the failure of the procedure, hemorrhage, and tedious flap making in DCR are the main cause of reluctance from this surgery. And as a result, nowadays DCR is ignored by many eye surgeons, particularly new eye surgeons. And lacrimal surgery is increasingly being undertaken by ENT surgeons. And in an era when other specialties are always looking to widen their surgical spectrum, we are losing our domain by ignoring this, and it is going in the hand of ENT surgeons now. First of all, I shall talk why DCR fails. And the cause, if you will do 100 DCR, approximately more than 40 DCR fail due to fibrous tissue growth in bony ostium, more than 10% because of collapse of bridge between anterior flaps, more than 15% due to some syndromes, 18 and more percent due to inappropriate size of location of the bony ostium. That comes second after fibrous tissue growth at a bony ostium. And common canaliculous obstruction in more than 10% cases, and intact lacrimal sac in more than 4%. For a successful DCR surgery, one should know anatomy, and appreciation of precise anatomy is essential to understand the process of DCR surgery. And should I escape this because everybody, and this is the lacrimal sac sits within the lacrimal fossa that bounds anteriorly by frontal process of maxillary bone and posteriorly by thin lacrimal bone. I'm skipping all these. Yeah. Preoperative clinical examination is must for any beginner. An alternative cause of EP4 such as evaporative dry eye, reflex tearing, eyelid malposition, punctal stenosis must be excluded at the time of examination, first examination of the patient, and the eyelid should be examined for malposition and evidence of meibomian gland dysfunction. And the punctum is inspected for size and location, and specifically as to whether it is in the tear lake or not. Examine for the absence of puncta and any fistula or accessory puncta, especially so in all children. And the cornea should be examined for punctate epithelial staining, tear film quality, tear film breakup time, epithelial defects, and infiltrate or keratitis. That means it is the other causes of tearing, and we go for DCR surgery without any profit to the patient. And the fluorescein dye disappearance test should be evaluated, and the nasolacrimal sac area should be inspected for presence of swelling or a mucosal. Very important point here, any swelling above medial canthal tendon is atypical and may represent malignancy of the sac mucosa or other pathology, and this should be investigated with imaging prior to proceeding to the DCR. And digital pressure is applied to the sac area, and punctum is observed for any mucoid reflex indicative of mucosal. During operation, nasal packing is the first step in my view, and it is done to keep the mucosa taut and reduce bleeding, and this should be explained to the patient. And anesthetic to the nostril with few drops of 4% topical lignocaine, then nasal packing inserted in the ipsilateral nostril with the help of nasal packing forceps, crocodile forceps, in the direction of medial palpebral ligament, that is superior, then posterior, then inferior. Anesthesia is always local anesthesia we use in adult and in child for general anesthesia. Lignocaine infiltration, I prefer a single point block in DCR surgery, and the preferred site of infiltration is upper inner angle of the orbits just medial to the medial canthus where MPL is situated. At the MPL insertion, the bone is hit with the 26 gauge needle and 2-3 cc is injected. Then the bevel of the 26 gauge needle rotated superiorly, then to 3 cc injected, and then rotate inferiorly while injecting the remaining to 3 cc. And firm pressure is applied for 5 to 10 minutes for the anesthetic to act. Cleaning is done with spirit and povidone iodine right up to the upper lip. One thing is very important, patients should also be informed before and during the procedure that there will be a sound of bone cracking. Otherwise, the patient is horrified most of the time. Not unlike when a tooth is extracted, and they may experience pain equal to or less than the associated with an IM injection. Just you have to console the patient, it is not going to pain more than an IM injection. Initial incision is very important. Mark the anterior lacrimal crest by filling patient's inferior orbital rim and then going up. J-shaped curvilinear incision is taken 3 to 4 mm from MPL for medial canthus, starting 2 to 3 mm MPL, about 1.5 to 2 centimeter in length. And identification and exposure of MPL is very important. These are the sac dissection. In sac dissection, ICL posterior crus of MPL is not disturbed. Otherwise, it may lead to pump failure post-operatively and watering post-operatively. Bony osteum creation. Extent of osteum. Anterior till the punch cannot be inserted between the bone and nasal mucosa. Posteriorly till removal of aerated ethmoid. Superiorly till 2 mm above the medial canthus. Inferiorly till the nasolacrimal canal is partially derived. Flap formation. In flap formation, I shall highlight using the probe as a guide. Incision is made with the help of number 11 or 15 blade right across the sac from the fundus to the nasolacrimal duct. Flaps are raised and the posterior one is cut. In case of overriding nasal mucosa during flap anastomosis, in case of overriding nasal mucosal overriding is preferable, or alternatively one can tend the flaps and suture to the overlying orbicularis. I am escaping the proper method because everywhere you will get it. And the wound closure is once flaps are secured, the orbicularis is sutured back to 606 of Vicryl and followed skin with 60 silk. And the second is the tips for the hemostasis. Good preoperative assessment to rule out bleeding diastasis. Preoperative blood pressure assessment, use of adrenaline along with local anesthetic provided there is no medical coordination, contraindication. Good nasal packing is good nasal packing right in the beginning if bleeding is anticipated. Raising the head end of the table, avoid known blood vessels. Generally, if major blood vessel is cut, chances of more around bleeding, and in initial phase it is very horrified for the doctor. And well powered suction, judicious use of cautery, keep material like gel foam or bone wax in the armamentarium. You can use mitomycin C and intubation and adjunctive measures. And useful surgical tips are ensure good anesthesia and hemostasis. After the initial incision, raise the skin flap and work between orbicularis and skin to avoid damaging the angular vein. Orbicularis fibers can be divided with blunt dissection using cotton buds. Avoid orbicular suture to avoid an unsightly scar. Orbicularis suture should not be cut. A back cut towards upper eyelid can be made perpendicular to the upper edge of the incision when the patient's skin is thin and prone to tearing. And adequate bony osteum is essential to ensure long-term success. And the take-home message for today is, for a skin incision, trace anterior lacrimal crest by palpating upward from inferior orbital to orbital margin. Restrict bone window to area between anterior and posterior lacrimal crest to avoid entering paranasal sinuses. Separate the orbicularis oculi and never cut them, otherwise unsightly scar. Avoid injury angular vein by making a skin incision on anterior lacrimal crest. If angular vein is cut, it is certain that your operating time is going to be double and triple. Thank you. Thank you for patience listening. Well, now we know what not to do, that is most important. Thank you.
Thank you so much,